Today is April 19th, 1983. I'm Don Berreth, Director of Public Affairs at the Centers for Disease Control. With me is Mr. William C. Watson, currently Deputy Director of CDC, and the two of us are going to discuss some of the earlier years of the Centers for Disease Control. Dr. David J. Sencer, who is the former Director of CDC and now Health Commissioner of the City of New York. Dr. Sencer, you arrived at CDC in 1960. What were your early impressions of the organization?
Well, CDC had just moved into the Clifton Road facility a few months before I came down and was trying to get itself adjusted to living in luxury after being mainly out at Chambly, where they still are, and downtown, and a variety of office spaces. But the center basically at that time was a self-contained operation that was beginning to move out of the old days of traditional research, investigation, demonstration into actual service to the states. This came about in '57 when Bill was transferred down here with the venereal disease program, which they finally recognized in 1957 to be a communicable disease, and combined it with the rest of CDC. And the tuberculosis program was coming down at that time. It was really sort of going through, I guess, really one of the big major changes of the center from being just an inward-looking, research-oriented group to one that was actually in the provision of public health advice and service to the states.
Dr. Sencer, you had been in the public health service for a few years before coming to CDC. Could you tell us a bit about your earlier career in the public health service, and how did you get to CDC?
I came into the public health service in 1955 in the tuberculosis program when it was still in Washington. And after being a code clerk on an isoniazid research study, I was sent out to Idaho to work with migrant labor. We were doing a health service migrant labor that was funded by the tuberculosis program, occupational health, venereal disease, variety of different programs, and I was the medical officer in charge of the program. Prior to that time, I'd planned...
And where was that now?
That was the Snake River Valley of Idaho, everywhere from Boise to Payette to Parma to Nissa to Caldwell, Nampa, the bigger communities of Idaho. I'd been planning on going back to academic medicine in Ann Arbor, but that summer I began to realize some of the fun and excitement of public health, and from there I was transferred to Columbus, Georgia to the tuberculosis research program, and began doing epidemiology, and that really convinced me that I didn't want to go back to a one-on-one patient relationship, wanted to stay in public health. Went to School of Public Health under the auspices of the Public Health. Went back to Columbus.
Where?
Small school that you attended on the other side of the river called Harvard, and one of the trade schools up there. The reason I really got to CDC was sort of an interesting one. I was on an airplane coming back from Mississippi to Columbus, and in Montgomery, Alabama, Bob Anderson, who used to be the chief of CDC, got on the plane. He was now up in Washington. And, no, he was still chief of CDC at that time. And Dave Price, who was a bureau director in CDC, was with him. And I spoke to Bob, and we chatted a little while. And about 3 days later, I found out I was being transferred to Washington. It seemed that Dave Price had been trying to get Bob Anderson to assign Alan Donaldson, who was the deputy director at that time, to Washington, and Bob didn't want to lose Alan, so he traded me from the tuberculosis program to Dave, sort of as a utility infielder, I guess. And I spent 2 years in Washington doing staff work, and then was fortunate enough to be transferred down here.
In the bureau that CDC
Bureau
was a part of at that time.
Bureau of State Services, and I was fortunate enough to be transferred here in 1960. I thought, you know, like most public health services.
How did that come about? How did somebody make you a job offer? Or?
Well, Larry Smith, I guess, went to Ted Bauer. And
who was Larry Smith?
Well, that's next on your list. Send it to me on the Roscoe. Larry was the director of the center at that time. He was becoming director Bob Anderson was being transferred to Washington, and Larry had been the chief of the venereal disease program and then had been the deputy director of CDC. He convinced Ted to transfer me to Atlanta, just a year experience, and I'd go back to Washington. And that was the beginning of 17 years of very happy work and living.
You came here as assistant to the director?
Assistant director.
Assistant director,
Yeah.
the number 3 person.
Number 3 person.
In CDC,
Yeah.
right. Okay.
And we were just trying to get used to having you around the executive office then too, because you were being transferred from the venereal disease program to become the assistant executive officer, and there's a great deal of resistance to that.
I know.
Yeah.
How well do I know?
Just like there was anything about the venereal disease program, the old-timers at CDC didn't like that.
What did Dr. Smith put you to doing at first?
Odd jobs.
Like what?
Home. He had me reviewing manuscripts, and he just sort of left me alone to find my own way, and then we'd get involved in the early days of oral polio vaccine. I remember we got quite heavily involved in that with the whole problem of licensure of oral polio vaccine. And I guess you used me sort of as a physician that wasn't really affiliated or didn't have any ties with the other groups at CDC. I was an outsider and helped to, in some ways, to integrate the tuberculosis program and into the rest of the center. But I was as number 3 man. I was doing odd jobs.
Let's set the stage a little better as to what it was like in 1960. Was there an epidemic intelligence service?
Oh yeah, there was an EIS. At that time, there was the Epidemic Intelligence Service, which was part of let's see, branches then. There was a technology branch, a laboratory branch, training branch, the VD branch, and a TV branch. And they just gotten away from having a administrative service branch. That had at one point been a line operation rather than a staff operation the way it is now. And I guess we had about 1,200 employees all told at that time, and most of those were in the VD program assigned out to the...
Half in VD,
Yeah.
right, yeah. It was during this era that CDC's immunization program began.
I was in '62.
Yeah. It was during Dr. Smith's tour as director.
Larry
right?
was the director. It came about because somebody in charge of public affairs for the Public Health Service by the name of J. Stewart Hunter got this bright idea of buying up all of the oral polio vaccine and distributing it to the states. He thought that'd be a good thing. It was a good, and he thought that'd be a good program. And we convinced some of the other people in Washington that that's what the Public Health Service had done in 1955 with Salk vaccine. They bought it, distributed it, but didn't give the states any money to give it. So the states had given it to the easiest groups that they could find. Those were kids in school, and they were missing preschool children. So we turned the immunization bill into a grant and aid program to states which they could buy vaccines, not just polio vaccine, but any kind of vaccine for kids under the age of 5, since that was the most susceptible group. And we started off in the bang in 1963, 62, writing grants all over the country. And
Well, was that made possible by the so-called Vaccination Assistance
that was
Act?
the Vaccination Assistance Act in 1962.
So
And
that had to be sold to the Congress. Was that a easy chore in those days?
It wasn't difficult. I remember Larry went up to the hearings, and the total briefing of the secretary consisted of a ride from HEW South to the House office building, and that's all that Ribicoff heard about it. And he got up, and it went through without any difficulty.
How much money were we talking about in those days? Less than 10 million?
Oh yeah, $5 or $6 million.
5 or 6 million,
Yeah,
as I remember,
yeah, right.
was the initial authorization.
Yeah, it was this small, but those days that was a lot of money.
Yeah, it was.
Yeah. We were very careful with spending it.
Is that the time that you had all the hoopla in Columbus, Georgia to...
Well, no, that was before then. Babies and breadwinners, if I remember the tagline. Everybody had thought that oral polio vaccine was going to be licensed, but through a variety of pressures and problems, it didn't get licensed. And so Dr. Smith thought it would be a good idea if we did something to keep people using Salk vaccine, and so we organized this program in Columbus, Georgia, and captured it on film, made a little movie called Babies and Breadwinners, and we found out that we immunized an awful lot of people in Columbus, but they were the same people who had been immunized the month before and the month before and the month before, and we had people jumping out of airplanes and getting stuck in trees, and we had your predecessor calling the Goodrich Company to get the Goodyear blimp, and a few things like that.
Big publicity campaign.
A big publicity campaign that didn't get very many people vaccinated.
Right, and that was the basic point we proved.
Right, yeah.
And that's not the way to do.
Yeah, public affairs won't do the
job. Before we leave those first couple of years or so, are there any people that you would like to
CDC was a people organization in those days, and there's still a lot of those people still around, people like Danny Sudia, and I saw Marion Brooke in the cafeteria the other day, but Alan Donaldson, I think in particular, was sort of the symbolic Mr. Inside of...
And he was the deputy.
He was a deputy director then. Alan was a parasitologist who'd grown up through the malaria program, and he knew everybody, he knew everything that was going on at CDC, and really personified to most people what CDC had been like. And we always used to kid Alan that when we needed the history of CDC, you'd go in and say, Alan, this button, and he'd push this button, and out would come the history of the center. But he was one of the very well liked, respected people around. George Tremmel was the executive officer at that time, and we had Pick Johnson in charge of the motor pool. Pick ran a good motor pool, but if it got much beyond that, he had some problems. And
what did you need a motor pool for?
Well, we really didn't, but we'd had one during the malaria program, and we never got rid of it. And but you know, back then they had trucks and bulldozers and all sorts of things to ditch and drain and dynamite, and
they were eventually given to the states, weren't they? I mean, that fleet of vehicles that we had was somehow...
They were declared surplus.
They were declared surplus. And
disappeared from CDC, but he's right.
The only other time we really got into the vehicle business was with the next director, Dr. Goddard, who was getting a haircut one morning, and he mentioned he was looking for a second-hand Jeep. And somebody in the barbershop said there were a group of children at Briarcliff High School who were selling second-hand Jeeps as a class project, but they needed a gross to put in the order, and there would be some ridiculous figure like $26 a piece. And so Jim said, sign me up, and he came back and told that story to one person in audiovisual. And by the end of the day, the phones were coming off the hook. We had orders for 1,100 Jeeps.
Out of CDC alone?
Out of CDC alone. And I saw John Motes, was it? He'd ordered 11. I said, John, why'd you order 11 Jeeps? And he said, well, my son's class has 10 boys in it, and I thought it'd be good for each of them to get the experience putting a Jeep together, so he got 11, one to show them how to do it and one for each of them to do it. One lady was going to paint it pink and put it in her front yard for petunias. Sarah Brown has spoken to us since, because we referred all the phone calls to Sarah Brown. She was getting phone calls in the middle of the night from people who worked at Buckhead. Why didn't you tell us? And then your predecessor had to find a way to put out a memo when it came up that Goddard had been taken, that there were no Jeeps, and George Stenhouse had to put out a memo saying the boss was wrong, there are no Jeeps.
I'm sorry, I signed that memo.
Well, George wrote it.
Okay.
All right, yeah. And this eventually got to the newspapers.
Well, we've made the transition from Dr. Smith's tenure as director to Dr. Goddard. There was a transition there. Do you want
There
to
was a
comment?
big transition,
Yeah,
yes.
okay.
Dr. Smith, CDC had been a place where people would come for 2 years and then move up to Washington. It was a stepping stone in a career, and Larry, I think, was the first person that really felt loyalties to the center after it had left being the old MCWA. And Larry was on vacation with his wife out in Hawaii. They'd gone around the world, and he was vacationing in Hawaii when the new Surgeon General called and said he wanted to see Dr. Smith. And so we got Larry back to the town. Harry Pettigo and I met him, and we got him back to town. And he said he knows that they were going to try and move him up to Washington, but he decided that he would rather move to Washington, rather stay at CDC rather than move to Washington and get that extra star. And so he was all set to tell Dr. Terry that he wasn't interested in the change. And Luther walked into the airport and he said, "Well, Larry, I've told Jim Goddard he's coming down to take your place and you're moving to Washington." And it was one of the few times that Larry Smith was speechless. He was usually quite articulate to say that day. And so that was the beginning of the 2 years that Jim Goddard was here. And Jim, I guess...
Shortly after that, now Dr. Donaldson left and went to Washington too, right?
Yeah, Alan went on up to become Larry's assistant director of the Bureau of State Services. But Jim, after about 6 months, walked into the room one day and he said, "Well, this is the wrong place for me." He said, "I either need to be in a small place and make it grow or in a place that's in trouble and shake it up, and CDC's in neither." And so then he just sort of went and did his own thing for the next year and a half and went on up to become, well, he was on...
And you became
deputy
director.
Yeah, and you became the assistant director along about in there. And
was Goddard's only experience with CDC the 2 years that he spent down
he'd
there?
been in the accident prevention program and in the employee health program, and just before he came here he'd been the chief air surgeon for the FAA, put in regulations for pilots, safety work, and done a very good job of it. And that was his thing. I mean, starting from something that was sort of a scandal to making it respectable. And he found out that Luther Terry, or no, not Luther, who was before Luther?
The Surgeon General?
Yeah.
Before Terry.
No, he found out that Luther was going to retire. That was it. And
That's right.
so all of a sudden Goddard began running for Surgeon General. He was on vacation out in Ocracoke, and our telephone bill from Ocracoke around the country was a little high that month, but he was trying very hard to become Surgeon General, but he ended up being the Commissioner of the Food and Drug Administration. And you used to work for him.
And when Dr. Goddard to become the administrator of the Food and Drug Administration, you became the next director of CDC. You want to tell us how that happened?
Well,
do you know?
No. I was on about that time, Bill Stewart had appointed a committee to...
Who was now the Surgeon General.
Who is now the Surgeon General. He'd appointed an outside advisory committee to reorganize the public health service. And when he found out that an outside advisory committee couldn't do it, he decided he needed some staff help. And I was tagged to be the staff person to help, along with Hod Ogden, and to write up what we decided. And we came up with an organization that had a Bureau of VDPEC, Disease Prevention and Environmental Control, and a Manpower Bureau, and NIH, and Community Health, and Consumer... No, and the Food and Drug was still separate at that time.
That's right. Food and Drug was not a part of the public health.
CDC was part of the Bureau of Disease Prevention and Environmental Control, and Dick Prindle picked me, I guess, because I was here, and I'd been on the reorganization committee, and but we had a problem then because he wanted to change it to, he wanted to have a bunch of national centers, and we fought like the devil to keep from becoming the National Center for Communicable Disease Control, and we wanted to keep the initial CDC. We lost that battle, but that didn't last long because another reorganization came along and we became the Center for Disease Control. And
At that time, we were still a communicable disease center.
Yeah.
Right.
Mm-hmm.
Do you know anything about that, his appointment, that he hasn't told us?
If he does, he
Well,
hasn't told me.
Not, he wanted the job by that time.
Well,
He
yeah.
liked CDC very much, and nobody had given him any assurance that he would get it. But the Public Health Service at that time was really run by the Commission Corps, and most of the top jobs held by people in the Corps. So he was a viable candidate, and he did get the job. And I think as a result of that staff work that you'd done in Washington, you were known in Washington at that time. And one thing he might not know is that Dr. Goddard promoted his candidacy for the job. Very much so. He was very much in favor of Dr. Sencer becoming director.
I told Jim no enough times. And no, you can't.
Dr. Sencer, CDC has had some programs like the immunization program that started scratch and started anew, but most of its growth has taken place by transferring in activities that were already ongoing in the Public Health Service someplace else. And a large part of that took place during your tenure as director. Would you like to
Yeah, well, there's
comment
one
on
other
that?
program that really was a de novo start, and that was a clinical laboratory improvement program.
That's right.
We'd been doing a certain amount of work in consultation, and suddenly we got pushed into a licensure program. Actually, the clinical laboratory program started as our proposal had been that it become a grant and aid program to the state so that the state health departments could develop their laboratories to give consultation to local labs. But by the time it got out of the morass in Washington, it became a national licensure program to license labs in interstate commerce. And, so that was the regulatory activity that CDC had been in. But the other big additions to the center, as you say, had mainly been through accretion of other programs. In the next reorganization of the Public Health Service, the environmental health, a lot of the environmental health programs were sort of, well, no, wait a minute. We had a great big program called the Aedes aegypti Eradication Program that we fought tooth and nail against because we didn't figure that it was a very good use of the Public Health Service dollar. It was a politically motivated, internationally politically motivated program.
Can you elaborate on that a bit now?
Yeah, the Aedes aegypti mosquito is the mosquito that transmits yellow fever.
Yeah.
And it's endemic throughout the Western Hemisphere and Africa. And back in the 30s, Dr. Soper, who was then with the Rockefeller Foundation, eradicated the Anopheles gambii mosquito from Brazil. And on the basis of that, figured that you could eradicate Aedes aegypti. And so in 1946, all of the countries of the Western Hemisphere signed a protocol saying that they would all agree to the eradication of the Aedes aegypti mosquito because the way the mosquito moves around, if one country didn't eradicate it, it could be easily transported, the eggs, to another country. And then in 1962, I think it was, the Minister of Health of Mexico gave the Surgeon General the last 2 Aedes aegypti mosquitoes in Mexico, neatly embedded in plastic, pointed out that the United States hadn't done anything.
I remember that.
And of course, you know, had to take everybody else's word that the other countries had eradicated Aedes aegypti, and we knew good and well that they hadn't. But from a political standpoint, they decided that we ought to eradicate it. Well, this was going to be a multi-million-dollar undertaking because the mosquito breeds in tin cans and old tires, and it's a domesticated mosquito. And to try and clean up the southern half of the United States and the Virgin Islands and Puerto Rico was going to be quite an undertaking, and there wasn't any yellow fever. And But we came up with a budget that was going to be $40 million the first year, and it was cut in half
To 20.
to 20 on the basis that the state health departments would put up the other half. Well, at that time, I've forgotten what the infant mortality rate in Alabama was, but it was something like 30 or 40. We could just see Alabama putting up money to prevent yellow fever in South America. But we went ahead, and that's when we got back in the motor pool business then. And I'll never forget the day John Barron, who was in charge of procurement and administrative services, came to me and he said, "Now, I'm not asking your permission or anything else. I'm just telling you, I think you ought to know, I'm about to buy 5 miles of muslin." I said, 5 miles of muslin? He says, yes. He said, the 80s Egypti program is going to buy 5 miles of muslin so that they can tear it in little squares, tie stones in the corner, and put it over the water barrels in the Virgin Islands where people collect their drinking water so that the mosquitoes won't lay their eggs in the drinking water. So we bought 5 miles of muslin.
And what finally became of the 80s Egypti program?
Well, it was transferred to Washington and then collapsed.
Right.
And at that point, some of the other environmental health were transferred back to CDC, including the rat program, which here again, it was a question of a program being given to another part of government, and when they can't deliver, they turn to CDC to do it. Congress had appropriated $16 million for urban rat control program during the civil rights disturbances in 1966, and this was going to be a grant program, and the engineers in Washington couldn't figure out how to write grants, and so we suddenly had to disperse $16 million worth of rat control money, and well, actually it was 15.25 because the first $750,000 went immediately in a check to Mayor Daley, and then we had the rest to work with. But this came back to CDC along with some of the other environmental programs and the lead program, and the big other addition was NIOSH, of course, with, in 1972. But I know what you're driving at. The quarantine program was transferred to CDC in 1966, and I'm not sure I should talk about that because I think I'm going to write a book about that. Tales that could be told about the old quarantine program are something. It was quarantine.
We won't impose the Relman rule on you.
The quarantine program started in something like 1796 in the Public Health Service, and had been part of the old hospital program, and then I think they wrote the manual in 1804 and transferred the program to us with the manual in 1966. And we were suddenly faced with a huge program of people. We had 606 people in the foreign quarantine program, people in every port, every airport. Along the U.S.-Mexico border, we're vaccinating 200,000 people, 800,000 people a year on the border.
Oh.
Smallpox, and there hadn't been a case of smallpox in Mexico since 1951, but we still vaccinated. We x-rayed all of the people who were border crossers, and 92% of the budget was in personal services. Well, you know, if you have to have that kind of money in salaries, you don't have much money to spend on anything else. And I think the best example of it, the travel budget for the man who was in charge of the U.S.-Mexico border from Tijuana to Brownsville, his travel budget was $75 a year. And so, you know how much he covered that border.
I gather what you're saying is that, in your opinion, the foreign quarantine program at that time was a bit antiquated?
Those are your words.
But what are you saying?
I'm saying it was foolish, wasteful, non-epidemiologically based.
So what did you do about it? And
Well,
you were director of CDC and it was transferred in.
We first thing that we did was to try and figure out how we're going to meet the budget, because Jim Kelly, who was the controller, wouldn't give us any money for the pay raise. And the old Bureau of the Budget had just done a time motion study and said we needed 144 more people to do what we were doing. And so we put a team out into the field to take a look at one quarantine station at John F. Kennedy. Jess Norman headed it up, and Joe G. Giordano had put it together. And after about 24 hours, Jess called back, and he said, "Doc," he said, "you got a problem, that you're overstaffed." And he said, "You got such things as you run 3 shifts a day at the airport, and you have 16 people on each shift. And the shift from midnight to 8, there's one scheduled arrival of an airplane, and you got just many people sitting there for that one plane as you do for the busy period in the afternoon." So when we looked at what he came up with at John F. Kennedy, we said we better do the whole quarantine service. So we did a management study of each of the quarantine stations over the next several weeks, put together teams that went out, and as we went, everybody says, "Have you been to Miami yet?" And because everybody in quarantine knew that Miami was really overstaffed. John F. Kennedy, we cut back 35%, just without changing any of the programs, just by changing management considerations. And got down to Miami, and it was about 50% overstaffed. We had former assistant surgeon generals who'd retired down there and inspected ships, and we had a doctor that rode the Electra out to Cuba once a day and back, and we had psychiatrists that looked at x-rays and radiologists that looked at vaccination scars, and we just were doing a very good job of protecting the country. So we began a RIF, which is terminology for reduction in force, much to everybody's consternation. You know, how do you run a RIF? I mean, that's never happened before in the public health service. And
that is literally true.
Yeah.
That was the first reduction in force in the public health service ever, I think.
Yep. And then we did such a good job of riffing that they gave us Aedes aegypti back to run a reduction in force on too. But we were very successful in reducing the foreign quarantine program in size, but not losing the positions or the money. And much of the growth of CDC after that was really out of the old foreign quarantine positions and money. That was about the time that Carl Tyler got started in family planning. The smallpox program was getting underway, and all of these things that we just sort of used foreign quarantine money to, and positions to get a lot of new programs off the ground.
Well, the early restructuring of foreign quarantine was simply better management. Later on,
we began changing procedures.
Right, and
quickly.
that must have resulted in some kind of an outcry that you would be subjecting American people to dangers from
absolutely.
overseas. How did
well,
you handle
the worst thing that happened when we said that we didn't need doctors at the quarantine stations. I mean, that was, that was just terrible, because I remember the medical officer in charge at Galveston wrote me a very nasty letter saying that by taking the doctors away, we were laying the country open to the ravages of smallpox, and that we would have epidemics in the streets and so on. That we did get a fair amount of that kind of flack. We stopped vaccinating at the U.S.-Mexico border. Oh, and Bill was with me when we went to the quarantine station in New Orleans one day, and there was a VD seminar, and we skipped out for an afternoon, went out to the quarantine station, and there was a doctor from Washington down with 3 stripes in his uniform, and we approached, he said, "We have the ship standing by for you." And we said, "What?" He said, "Yes, the ship's standing by." He said, "Why?" He said, "Don't you want to ride up the river?" He said, "No, we came to the quarantine station." And nobody ever visited the quarantine station except take a ride on the boats up and down the Mississippi. Of course, I was afraid to get in the boats because they weren't seaworthy. This physician, among other things, took us into the office and went through the stack of vouchers, and he said, "Now all these vouchers come to Washington for me to approve." And we were looking, went by, and there were $10 here, $8 here, and he said, "I disapproved this one." It was a $13 voucher for gasoline for the lawnmower, and he said, "They tried to charge this to maintenance, and it's really a supply, so I disapproved it." And they were buying smallpox vaccine in 10-dose vials or something like that at a horrendous price of $1 something a dose. we came back and asked John Barron if we could get a better price, and he came back and said, "Would 2 cents do?" And so it was a combination of just facing up to what the epidemiologic situation around the world was. We weren't going to get importations of disease, and even if we did, quarantine wasn't going to stop them because of incubation periods and rapid air transport.
So instead of just changing the outdated, outmoded management, you changed the program.
We changed the program, too, to one of, this was our big justification for using the money for the smallpox program. It is cheaper to eradicate smallpox overseas than it was to keep all these people standing at the border checking vaccination certificates. And that was sort of the basic principle that we went on. And then also the concept of surveillance. We signed a few people out to states on the basis of surveillance. And it was a real basic change both in management and intent of the program.
Of course, the EIS had been established on the basis of a screen against biological warfare.
Yeah, this was sort of this was before my time, but they were up to testify before Congress on the budget, and all of a sudden they said, "What are you going to do about biological warfare?" It was the beginning of the Korean War, and Justin Andrews, who was the director then, thought real quickly, and he said, "Well, we're going to recruit these epidemiologists and assign them out to the states to recognize rare occurrences of disease." And that was the beginning of the EIS in 1951, 52.
You mentioned that some of this money was used for the smallpox program. Was the smallpox program ever an appropriated item, or was it always...
Well, we never got any appropriated funds for the smallpox program. There was AID money that paid the big hunks. But we had enough money so that when somebody was needed someplace, we could go ahead and do it rather than have to go through the AID bureaucracy. This was one of the nice things about being down in Atlanta, that we could get things done. I think the plague epidemic in Java was a good example of this. I got a phone call at home on a Thursday. It was Washington's birthday, a holiday, and it was somebody from the State Department saying they'd gotten a cable in from Jakarta saying there was an epidemic of plague in the mountains of central Java, and they had a list of things they wanted, which included cyanide and gas masks and all sorts of things for killing rats on ships. Well, if the epidemic was in central Java, it wasn't going to get aboard ship. So we said, why don't you cable back and say, don't you need some epidemiology and vector control and plague vaccine and a mobile laboratory? And on Friday, we got the call back saying yes. I guess it was Tuesday. I won't embroider it too much. Tuesday was the first call. By Wednesday, we had back everything that they wanted, which was plague vaccine, laboratory equipment, epidemiologists, vector control specialists, laboratorians, serology, and gas masks and cyanide. We got to work, and by Saturday, we had everything put together at the airport in San Francisco with 5 people and all of the laboratory equipment, the gas mask. We didn't have the cyanide because planes wouldn't fly cyanide, but we got that flown down from one of the military bases in the Philippines. So if you'd been in Washington, you couldn't have gotten that done, but with the type of administrative support that CDC has, and this was one of the, I think we talk a lot about the glamour of the epidemiologist and the glamour of the laboratorian and the guys who go out and net birds and ban birds and bleed birds and collect mosquitoes and so on. But it's really the administrative support behind all of this that has made it possible. Being an agency outside of Washington, we have I still have a little bit of difficulty with my identification. Your own budget shop, your own print shop, your own personnel, procurement, and it just faster because these people are part of the organization. In Washington, they're not part of the organization. They're just part of a big superstructure. And the people in our administrative and support services take pride in the organization. They're part of it. And Bill tells us the story that I think is so true. Of one day somebody came into his office and pounded on the table and said, "Have you looked at the flag?" It says, "Dirty. CDC shouldn't have a dirty flag. it's this attitude that people really identified with the organization and made an awful lot of the things that the glamour side get credit for is really because of the support. It's somebody making sure that there's media, that there's glassware, that there are all of these things in the laboratory, somebody that's getting the travel arrangements and so on. Doesn't happen in other parts of government.
You referred to the transfer of the National Institute of Occupational Safety and Health into CDC. Now, as I remember, there were two transfers. The first one didn't stick. It was abortive. Do you want to talk about NIOSH for a minute?
Well, yeah. Well, really, I'm not sure abortive was. It was sort of a delaying action. In the 1972 reorganization, I think it was, NIOSH sort of became
of the Public Health Service.
Of the Public Health Service. It became sort of a stepchild. It wasn't in anything else, and we made the proposal to become part of CDC because it was preventive medicine. Well, the next day I was informed that they were going on closed-circuit television around the country to announce to all the regional offices that NIOSH was headed up by a new director, and it would report to the assistant secretary. But we were in the same cluster of organizations in Washington, and then when that all sort of straightened out, it was just a matter of a few months, I think, that before it became part of it. And this has been a very difficult, was and still is, I think, for the center, a very difficult transition, because here was something that had a legal mandate, had a completely different constituency than CDC did. CDC's constituency were state and local health departments, and here suddenly the constituency was labor, and it was a completely different ballgame. The basic principles of occupational safety and health are no different than the basic principles of any disease control program, but it was more one of constituency and of separateness and wanting to maintain the old Bureau of Occupational Medicine, Occupational Health. Public Health Service had been a little teeny thing, and suddenly it mushroomed into a national institute. And they naturally felt pangs of wanting to be separate, wanting to be important, wanting to have visibility, and they couldn't accept the idea that they could maintain much of that even within a general framework of CDC, but it has come to pass, and I think that if you look at the caliber of the work coming out of NIOSH, it certainly has improved in terms of the scientific component, particularly the epidemiologic aspects of it. I'm not sure I mentioned it to you, but one of our EIS officers in New York, we're talking about setting up a sort of a rump meeting on AIDS during the EIS conference, and our EIS officer in New York said, well, please don't have it on Tuesday morning. That's because that's the morning, and they always have such good papers. So that it's become recognize that this is good work that's coming out of there, and I think it's benefited by its association with the center, even though they do wear uniforms on Wednesday.
During that time, there also, or as a matter of fact, before that, the transfer of the responsibility for the MMWR to CDC.
That was 1960, yeah.
You played a role in that.
Oh, I was just a minor role. I was still in Washington at that time, and Russ Alexander, who has now come back to CDC, was the EIS officer who was playing the role from Washington. It had been part of the old National Office of Vital Statistics, and it was really sort of non-vital information that got published. They had nothing. They had no response mechanism to any information that came in, so we got it transferred. Part of a 1960 reorganization down to CDC. They transferred $16,000 and half a position, I think.
And they still think you stole it from them.
I'm surprised anybody remembers they had such a turnover.
How much appreciation within CDC was there for MMWR at that time?
There was disdain. I mean, it was it was Carl Dower's sheet, and Carl Dower, statute limitations are over. Carl Dower it was well known that he saved most of the good stuff to put out in the newsletter he wrote on his spare time for Park Davis. And so what got in the weekly MMWR was just the leftovers from what Park Davis was publishing. And it was not an instrument that was used to do anything with. It was just a collection of dead data. And when it got down to CDC, Alex Langmuir and I really began working with it to turn it around to be a timely publication. We were prideful of the fact that it never missed a publication date, rain, snow. I remember Jim Payne coming in the middle of snowstorms to get it printed when the rest of CDC was closed. And also remember trying to put it into a computer. It was a losing battle at the beginning. And,
it's taken several years, several decades.
Yeah, we tried.
Then there was a nutrition program that was transferred into CDC.
Had dinner one night with Joe English, who was the physician in charge of one of our umbrella agencies called HISMAHA, Health Services and Mental Health Administration, during the Johnson days. And they had contracted out a 10-state survey on nutrition that was politically motivated rather than anything else. It was to show that there was poor nutrition, and the sample was biased to show that. But they couldn't get the data out. They just couldn't figure out how to do it. And so we made a deal with Joe that if they transferred the nutrition program to us, we'd get it out, and we could set up some demonstration projects in nutrition. And this was all over dinner. Jim Bloom and I were having dinner with him someplace in Georgetown, and we were going to...
There was a lot of political pressure to get that survey out, as I remember.
Well,
get the results
yes,
done.
There was a great deal of political pressure to get that out. And it had been started under the Johnson days, and by the time we got it, it was Nixon days. And we got it out, and we made, we gave it to the department to deliver to Congress, and they gave it to the House, to the Republicans, but not to the senators, to the Democrats rather. And George McGovern, who had been very much interested in this as a political tool, took to the floor, and I'll never forget that day because he was calling me a liar and a variety of other things. And I got home that night, and I had a letter from George McGovern asking for a contribution to his political campaign. But the program did come down here, and it floundered around for, flounder being a saltwater fish, you can eat it as often as you want. And gradually it evolved into, I think, a very solid program of assessing nutritional status and doing surveillance of nutrition in this country and abroad. And really it was, we built upon the, again, we talk about overseas experiences, being able to use them. More often we're able to use overseas experience back in this country than we are to use U.S. experience overseas, and I think nutrition and smallpox are good examples of that. Many of the things that we learned in smallpox are now being applied in measles, containment and elimination as a domestic disease in this country.
It was one of CDC's earlier efforts in non-infectious, non-communicable disease activities too, right?
Yeah, it started off with a Biafran conflict in Nigeria is when we first really got interested in nutrition because of the reports of malnutrition among the people who were affected in the war zone. Bill Foege, as you remember, went over for 6 weeks, 6 months before he came back. Really set up the nutrition surveillance activities in the war zones, and the things that Bill and the rest of the people who went on over brought out of there were, I think, probably classics in the annals of nutrition, but the methodology that they brought back we've been able to apply to domestic nutrition. I think that's, you know, this was the one time that we truly lost one of our EIS officers in active duty. One of our physicians was on a plane that exploded landing in Lagos and was killed. And,
Smoking and health. That was a program transferred into CDC too.
well, in and out.
In and out again,
But
right.
I think, again, lingering behind that was the fact that it was one of the is to get CDC into the whole area of prevention on a more generalized basis than on specific vaccine preventable diseases or epidemic containment and surveillance. This was an opportunity to use some of the modern techniques of health information, health education to begin to look at risk factors and then begin to not just talk about them, but to do something about them. And I think this is one of the things that Bill Foege has so wonderfully capitalized upon is this whole general concept of moving the center away from disease-specific to condition, I guess I'd say almost condition-specific sorts of things. The concern about preventing premature death and disability through primary prevention, not just through rehabilitation or early diagnosis, getting at primary causes of nutritional problems, of smoking problems, of violence, and so forth.
And as I remember, what you attempted to do was take the smoking and health program that's transferred in and build a broader base
of health
Bureau
education,
of Health Education around that.
But here again, we got into vested interests. This was a vested interest of one person who didn't want to move, and so we never really were able to get the whole smoking program to come to CDC. They had some very excellent people in the Washington operation, Dan Horn and Dr. Green and so on, who just didn't want to move, and we felt that really incorporating it into the overall opportunities that CDC had for dissemination of activities through our field staff and contacts with the states, that they would benefit from being here rather than just being a little clearinghouse for information in Washington. They could become more action-oriented here. And this was the beginning of the Bureau of Health Education. And, we took nutrition and smoking and built health education and chronic disease on that.
And dental public health.
Yeah, fluoridation. You pick up a little thing here and a little thing there, and pretty soon you've... well, actually what happened over the years is that all of the true public health programs have...
Of the Public Health
Service. Of the Public Health Service have come into CDC. As you know, NIH is more and more involved in medical research and education and manpower and so on. We have become, or you have become in Atlanta, the more traditional but still essential parts of public health, the concept of real primary prevention.